So before we get started with the subject matter, I do want to go ahead and take a few minutes to provide you just a little bit of information about Aspirion, just in case some of you may not be as familiar with our company. So Aspirion provides services to hospitals all across the United States for the most complex segment of the revenue cycle. We focus on claims that need specialized investigation, billing processes, and resolutions such as MBA, work comp, VA, and out of state, especially claims that need some legal support, as well as the claims impacted by revenue integrity issues such as your denials, your underpayments, and just general aging AR for a variety of issues. So we think we have a great team here at Aspirion that have the expertise to get these claims paid for you. That team consists of over 180 attorneys and legal professionals, more than 80 clinicians, and our technology experts, which include data scientists and engineers who are leading our developments in business intelligence, machine learning, analytics, and automation. As far as VA in particular, we started offering VA services back in 2014 at the request of several of our clients. The Veterans Choice Program had just come into place, and the whole intent of that Veterans Choice Program was to increase the ability for our veterans to get the care that they needed through the community facilities. So that was driving up the volume that a lot of our clients were experiencing, and they kept reaching out wanting us to take it off their hands. Our focus at that time was motor vehicle, third-party liability, and workers' comp, so we weren't real sure how much we would be able to help. They kept asking, so eventually we decided to run a pilot with one of them, and so we did set that up. But because our headquarters was there in Columbus, Georgia, which if any of you have military families, you're probably familiar with Fort Moore or formerly Fort Benning. We had a lot of employees that were part of military families. A lot of them were military spouses. And Fort Benning was so important to our community at the time that if we were going to take this on, we wanted to make sure that we did a really good job with it. So we hired a consultant. We met with the local VAs. We really tried to put together a good program for handling these types of claims. And, we were able to really make a difference for the client that we had in the pilot program. So we started offering it to our other existing clients. And we were able to do a good job for them and really increase both the amount of money that they were collecting and also expedite it. Those first years were kind of rough. When we got days to pay at about 120 days, we thought we were doing a pretty good job back then. But we have really continued to work on our VA services over the years, and we feel that we have very strong results for our clients in this issue. And it has been our fastest growing service line for many years since then. So today I want to just introduce our speakers. So my name is Lipocky. I have been here at Aspirion since we started back in 2006. I've worn many hats over the years, including president of complex claims, and I currently serve as an executive advisor. Excuse me, it's a new title for me. I'm getting used to it. It's my pleasure to have two of our VA subject matter experts presenting today. So I'm going to turn it over to them to introduce themselves. So Joseph, why don't we start with you?
Good afternoon, everyone. My name is Joseph Sawyer. I'm an operations manager for the VA and TRICARE department here at Aspirion. I have been with the company for going on 5 years now, but I'm excited to be here and thank you all for spending some of your Wednesday with us.
Hello, hello. My name is Rebecca Weise. I'm currently the VA TRICARE team lead trainer. I've been with Aspirion since 2019, and then I started working VA claims in 2020. I've been training since 2022, serving as an expert in VA and TRICARE medical claims billing. So we are very, very excited to be here and share all of the information that our team has pulled together with you. I am going to go ahead and also give us the highlights reel for today's agenda. We have a lot of exciting things we want to go over. We're going to start with the problems, which you're probably already aware of. If you're here learning about it, you may be struggling with these already. And we want to talk about assessing all of the opportunities that exist to increase and accelerate collections with these specific claims, including some of the industry benchmarks and performance indicators. Then we're going to get into what is hopefully the most impactful part of this presentation, which is our recommendations for best practices. And then, as Lori said, hopefully we'll have time for those questions that you have for us. So, because we have so much to go over, Lori, you want to take it away from there?
Okay. Thanks, Rebecca. So let's just level set a little bit and talk about the VA as it is today. So healthcare is only one of the many benefits provided by the Veterans Administration, but the healthcare services that they provide do make up our nation's largest integrated healthcare system. They have over 1,100 sites of care that include hospitals, clinics, nursing homes, counseling centers, and more. They also provide the largest medical education and health professional training programs in the United States, because they train more than 90,000 health professionals each year. So, but despite its size, the VA cannot handle the medical needs of our nation's veterans without assistance from community providers. Not only has the VA population increased over the years, but that population is aging as well, which is increasing their need for health care. Now, the VA's reliance on community care is nothing new. It's always been used to supplement the VA going back to World War I. But eligibility requirements have evolved over the years, and the names of the programs have also changed. Some of you may recall when it was called fee basis, and then later it was called purchase care, and now the term is community care. The Veterans Choice Program I mentioned earlier was always intended to be a temporary solution in response to those issues hitting the headlines back in 2014, but the plan was always one to come up with a more permanent program. Now, that permanent program came in the form of the Mission Act back in 2018, and the whole intent of the Mission Act was to make community care even more accessible to our nation's veterans. So it replaced the Veterans Choice Program and created the Community Care Network. It also established some availability for care through urgent care locations. And it was intended to improve it not only for veterans and their families, but for community providers and VA employees as well. And so when we look today, they have improved in many, many areas. I mean, the Mission Act did bring about a lot of positive changes for VA claims processing, but collecting from this governmental program can still be pretty difficult. There's a complicated system of varying eligibility and payment funding based on injury and treatment type, and it's still problematic for many providers, and we find that there's still a great deal of demand for VA outsourcing services. That low reimbursement makes it really hard to allocate resources that can develop the expertise that you need for successful collection. And there still remains a lack of confidence for timely payment. There are also new programs and process changes that occur frequently, so monitoring these changes can be very time-consuming. Some of the improvements made by the VA have been offset by the difficulty in obtaining revenue cycle staffing, but overall, we have seen improvements in VA processing over the 10 years that we've been providing these services. So many providers still struggle with getting paid and getting paid timely on their VA claims, especially without a lot of rework. This is usually a result of claims being rejected or denied by the VA, which is often related to not billing the appropriate division of the VA with the correct information and some other related issues. So Joseph and Rebecca are going to talk about some of the issues providers often see and walk you through a few examples. And I believe Joseph is going to get us started.
Thank you, Lori. So let's start with the VA payers are always going to be based on the type of care for your patient. The processing requirements for your VA payers is going to vary depending on your type of care. For pre-scheduled care to start, this should always be authorized through the VA or through VACCN. This care is not considered urgent, and a pre-authorization is required in order for your claim to be processed for payment. Urgent care doesn't always require a prior authorization, but it does require a notification to be obtained to have the necessary information to bill your claims. The notification is needed to confirm the patient's urgent care eligibility and obtain the referral number. It is really important to note that a patient's urgent care eligibility is completely separate from their VA benefit eligibility. And for emergent care by definition does not require a prior authorization, but it does require that a 72-hour notification be made to the VA in order to understand how that claim needs to be billed. Once that process is done, it will guide you as to which VA payer or OHI that should be billed for those services. And not understanding these requirements can have a negative impact on your collections overall. Next, let's walk through some patient examples that show what the billing process may look like for each of these types of care and some of the common issues we come across while processing each of these types of claims. Okay, so first we have patient number 1. This is going to represent our emergent care. As you can see, the total charges for this patient was $12,265. In this scenario, the patient is going to be transported to the emergency room by ambulance. At presentation, the patient states that he does have VA coverage and they are registered in the facility system under VA. However, in this instance, the 72-hour notification was not made to the VA, and as a result of that, the claim had to be billed directly to the VA as unauthorized care, which most often will shorten your timely filing limit to 90 days instead of 180 days, which you would have with your VA CCN payers. And due to the manual review process that the VA has, this will result in delayed processing and even a reduced reimbursement. In this scenario, if the 72 notification had been made to the VA, that information would have been reviewed. They would have created an authorization. And once that was billed to one of the third-party administrators, Optum or TriWest, once that claim was received for processing, you could receive payment within as little as 10 days. Next, let's take a look at patient number 2. This patient is going to represent our urgent care. As you can see, they have total charges of $980. This patient presented to the urgent care. They stated they had VA coverage. However, at that time, the patient's urgent care eligibility was not verified and a notification was not made. When the claim was billed to the VA, it was denied for no referral on file, and the balance was left as the provider's responsibility. In this case, if the notification had been made and their benefits had been verified, the claim would have been billed to the VA CCN payer, so Optum or TriWest, depending on your region. And the claim would have been paid and processed in a more timely manner. Now I'm going to go ahead and pass it over to Rebecca, who's going to go over the next couple patient examples with y'all.
Thanks, Joseph. So the next 2 examples we want to look at are for this pre-scheduled care, where pre-authorization becomes so important. So with this 3rd example, we have our patient number 3 with the charges of $21,365. This is an example of things initially being handled very well. There was a VA authorization on file, but unfortunately in this case, the treatment plan exceeds the authorized number of visits. And because no authorization extension was requested, these later claims are denied as the treatment not being authorized. And again, this is going to represent lost revenue. These claims are going to deny, be left to provider responsibility. If the authorization had been updated to include that scope of treatment, these also would have been billed and paid promptly, likely through VA CCN. In our 4th scenario, things are a little bit better. We, again, have pre-scheduled care. In this case, there is an authorization obtained, and it does cover the entire visit. With a balance of $48,980, you would certainly want that to be paid. In this case, though, we still end up with a denial for no authorization. This could be because the authorization was incorrectly put on the claim, or if it was missing altogether. This denial causes a delay in processing because it needs to be rebilled as a corrected claim, and it's going to pay in more like 60 days instead of 10 days or less. So with the interest of keeping AR days short, you would really want to make sure the authorization did not only exist, but it was being billed on the claim exactly as it appears on the referral paperwork. These are a lot of the common claim denials and rejections that we see. And as I just mentioned, these are a major drain on your time and your resources. Understanding these common denials and rejections can really help you with preparing ahead of time to keep them from happening. The VA, especially the VA CCN payers, have really strict rejection criteria. That's part of how they manage to process so quickly. But that means that you will see a large number of rejections due to things like the patient or subscriber's ID number being incorrect, or the authorization just being the wrong length or the wrong format. Optum and TriWest are even as strict as rejecting claims if they're not listed as the only payer on the claim, since they only process authorized care as the primary and sole payer. Listing them as the secondary payer on a claim causes a rejection off the front end and potentially problems with timely filing later on down the line. Denials are varied. They can be payer specific. Either VA CCN or applying to all three of the VA payers. Definitely you want to pay attention to trends here. These denials are going to cause a lot of delays. Really a big problem that we do see is claims being billed to the wrong payer altogether, causing denials from one payer because you should have been billing another altogether. Lori, do you want to take it from here?
Okay. I'm happy to, Rebecca. Thanks. One of the things that we get asked a lot whenever we're talking to a prospective client or just providing VA education out in the marketplace is, how can you tell if you're doing a good job or not? And what does good look like when you're talking about VA collections? So now that we've touched on just a few of the issues that may be delaying or preventing payment from the VA, let's talk about some key performance indicators and benchmarks that we use to help determine how well collections are going on this segment of your revenue cycle. So as I mentioned, these are some of the things that we use to evaluate our own performance so that we can make sure that we are maximizing collections for our clients. The first one that we look at is success rate. So we define success rate as when a claim comes to us, it's been identified that it should be being billed to the VA. How often are we actually able to get that claim paid by the VA? So it's a pretty simple calculation. There's a lot of things that we look at, but it's just was it the claim identified as being a VA claim, and did payment come from the VA? So we certainly look at unpaid claims, and we provide that data back to our clients to help eliminate the unsuccessful claims. The reason the goal isn't 100% is that there will always be accounts where the patient requests that the VA be billed, but they don't meet the eligibility requirements for their specific type of care that they're obtaining that day. We also see claims where the opportunity for payment by the VA has been lost due to issues regarding unauthorized care or maybe timely issues. I think as Joseph and Rebecca mentioned, when you're dealing with a mill bill claim on, coming into the emergency room, that your timely filing is much shorter than when you're dealing with your authorized care or other sections of the VA. So sometimes that leads to some denials for timeliness. There also can be some coordination of benefit issues that are impacting VA reimbursement, or it may be that the type of care just is something that the VA is not going to cover. So some of these types of issues are usually outside the control of your billing team, but even so, we still want to see success rates of greater than 90%. And we expect for our own internal teams that those success rates be greater than 95% after we've been engaged with a particular healthcare system for several months, because we've invested heavily in our ability to really understand what's going on with your inventory and be able to share back some corrective actions that we see may help improve getting claims paid by the VA when appropriate. So collection rate, or the yield, is also an important metric. We look at this as what percent of total charges did you actually end up collecting from the VA? So VA pays based on Medicare fee schedules, but we often find that collection rates are lower than they should be because a lot of times you're just relieved to get any payment from the VA, and you may not look that closely at what you're being paid for, and you don't often push back when a claim has only been partially paid. So we typically expect acute care facilities to kind of fall between a 20 to 24% collection rate. With your critical access facilities, of course, their collection rates are going to be significantly higher. We also want to make sure that we're looking at the timeliness, because we know that's just as important as, getting paid, because you certainly want shorter AR days. You want to get paid faster. So days to pay should average less than 30 days across all VA payer types combined. Now, when we run this metric, we are looking at whether the claim was paid by community care, whether it was processed as a VA fee basis claim, or whether it was processed as a mill bill claim, or whether it's being something that is going through dependent care through CHAMP VA. So, of course, VA community care through Optum or TriWest should be paying in less than 10 days. Your fee basis takes a little bit longer. And then, of course, CHAMP VA is still kind of the problem child of the VA payers. So when you average those together, you still want to be, less than 30 would be the target for your VA. Now, your results can be impacted by the amount of emergent claims that end up being unauthorized and that are getting reimbursed as a payer of last resort through the funding set up by the mill bill. So those are only going to pay 70% of Medicare. So that if you have a lot of those claims in your inventory, that's going to bring down your collection rates. It also may impact your timely filing. The other issue that you can have is your days to pay will be negatively impacted if you're not adhering to the notification requirements for the VA on the ER claims, which I know we're going to touch on that in a little bit more in our recommendations. Some other key performance indicators that you really want to consider is you want to know what's happening to delay or prevent your reimbursement. How often are you having to resubmit the claim for some of the issues that I think Rebecca touched on? Some of them are just kind of housekeeping issues. Some of them are just clerical in nature that are preventing you from getting paid with a clean claim the first submission. How often are you having to file for reconsideration because the VA has denied the claim? It could be an issue that you're not going to be able to overturn if it's related to certain types of authorization issues. It could be some that require corrective coding. But a lot of these claims are just the VA is processing incorrectly. So they just need to be resubmitted. But knowing what's happening and what the reasons are for having to resubmit your claim is an important factor that we encourage you to look at. So as I mentioned earlier, we have had to make a lot of investments in the ability to really dig deep and try to find what is causing some of these delays or these denials within the inventories that we manage. So now I'm going to turn it back over to Rebecca and Joseph for them to talk about the recommendations that we have for best practices.
Thanks, Lori. Yes, we want to get into the good stuff. We want to cover all of the highlights for our best recommendations. The first thing we want to make sure is you have a good, solid understanding of the VA payer structure, with having those 3 unique payers that can make a number of things very challenging. Then we're going to split the claims process into a few sections. We want to touch on patient access training first, making sure your registration team is really well prepared to deal with these VA patients, both obtaining information, verifying eligibility, as well as those notifications and authorization requests we've already discussed. When it comes to billing and claims management, I think there are important things to consider around coordination of benefits, understanding how timely filing works for these different payers, as well as going a little bit deeper into rejection and denial resolution. Once you have those areas cleaned up, obviously tracking your results is going to become really important, and we do have some resources for you to stay up to date on policy changes as time goes on. So the VA payer structure, we have 3 complete separate payer systems here. The main VA claims processing system, which is still often referred to as the fee basis system, is not a singular entity. They are a big organization with a number of smaller departments. They have put a lot of effort into streamlining their processes. So they have resources like a centralized claim line, a centralized billing address, things like that that make things a little bit more straightforward. But we do also have these community care network contractors, TriWest for the West regions and Optum for the East regions. It's going to be incredibly important for you to know which of those two community care network contractors you are dealing with based on your region, as that is going to impact which authorizations you can and cannot use. If your facility is physically located in the Optum region, you cannot bill claims to TriWest with TriWest authorizations. Those end up being rejected or denied for out of network. Knowing that all of these are separate payers is going to affect who you call for what information. Because Optum and TriWest are subcontractors, they don't have as much information for you on eligibility and authorization status as that main VA system does. It's also going to affect provider credentialing. You will need to be credentialed with your CCN payer and this main VA payer separately. And if you fail to register your providers with both, that's going to cause credentialing problems. Also, timely filing is a factor, both with those extended AR days and just loss of revenue in general. Billing the wrong payer is a huge problem. So understanding how to register patients correctly is really going to set you up for success, knowing which of those payers to bill. Joseph, do you want to share more about patient access?
Yes, thank you, Rebecca. To move on to our second best practice, which is your patient access training, really focusing on that registration part of the puzzle. To start off, it's really important to always obtain the necessary information you need from your veteran patients. It's important that you're asking them the right questions. So, for example, has the patient been seen by the VA in the last 24 months? Has this impacted their eligibility? What is the name of the local VA medical center that the patient is registered at? Where are they seen? In the case of service-connected conditions, do they have an existing authorization on file for those services? And if their care is not authorized, do they have any other health insurance that should be billed at this time? Moving on to verifying the patient's eligibility, it's really important to be familiar with the different methods you have of verifying their eligibility. To start off, the 10-digit member ID code that's on the VA card that you may see in your facility scans, it's important to understand that's not an ID that you can bill on your claims. Sometimes registration staff may add that in error, but later down the line, it may cause issues with billing your claims. The only two member IDs that are accepted by the VA are either going to be the patient's social security number or either their 17-digit MVI ICN number, which is a unique ID for that veteran issued by the VA. It's important to note with that MVI ICN number that the VA does have future plans to move to that exclusively as that member ID. So it's important to maybe go ahead and start making a practice of trying to obtain that at the time of registration. The VA does have a centralized call center that can help clarify any eligibility or authorization questions you may have. Or you can also use your VA CCN, so your third-party administrator, Optum or TriWest portals, to be able to quickly verify your patient's eligibility and actually check claim status as well. When it comes to reaching out to your local VA, that's only going to really be needed when addressing very specific referral or eligibility questions. Another thing is that because of the sensitive nature of the patient's member ID, often their social security number, it may be required that your billers have to reach out to them after they leave the office to try to obtain that information so we can get their claims billed out. It's really also important to understand what's required to be eligible for VA coverage, and we can't always assume that veterans understand this themselves. That understanding in itself will also help with billing, because down the road, when it comes to claims denial that you're receiving, they can actually reference these eligibility requirements directly. VA eligibility requirements can also differ based on additional factors related to the treatment and the funding mechanisms for payment. And there's also new legislation that's expanded coverage for mental health care and burn pit exposure specifically, and those may have their own unique eligibility requirements as well. Looking at things from a treatment-based perspective, For non-service connected treatment, such as emergency care, is the patient eligible for VA benefits at all? So have they been seen in the last 24 months at their local VA medical center? And are they showing active coverage with the VA? And the last thing I wanted to throw in is that I apologize. I'm now going to go ahead and pass things over to Rebecca, and she's going to go into some additional detail on some authorization and notification requirements for these claims.
Absolutely. Thanks, Joseph. And I do notice in the QA, there's a lot of questions about authorization. So hopefully just as we go through, we're going to answer a lot of those for you. When it comes to pre-authorizations in particular, anything that is non-emergent or non-urgent care, making sure that you do have that authorization on file, that you are submitting a request for services to the VA is going to be really important. As treatment plans evolve, you may need to submit additional requests for services in order to expand that authorization to cover your treatment plan. This pre-authorization is required. They put the impetus on obtaining and having that authorization on providers at this point, more so than patients. The expectation, if you are a contracted community care network provider, is that you must ensure that an authorization exists prior to admitting the patient for any care. If you do have a patient who wants to use their other health insurance, the best practice recommendation is to make sure that you have that other health insurance on file and you have the patient sign a waiver stating that they know that other health insurance is going to be billed. This can save you later on down the line if the patient does come back later insisting that the VA ought to have been billed. Verifying these authorizations, the scope of them, exactly what they cover in terms of number of visits, validity dates, specialty is going to be really important to do upfront before the patient is ever seen as that treatment is being prepared for. When it comes to other types of care, like urgent care, this is where notifications become really important. If you do have an urgent care facility as part of your network, this notification should be made at the time of care or at the very least the same day. Now, we have seen mixed results depending on the region when it comes to backdating these referrals. These notifications are being made to these CCN contractors directly, so they can have separate policies here. Optum, in our experience, has been much more flexible about backdating these urgent care referrals than TriWest has. So it's really important to know which regional contractor you're dealing with and stay up to date with their urgent care policies specifically. There's not a lot of information needed to make these notifications as long as you have the correct number for your region. They really just need you to identify your facility and the patient. If the patient is eligible for urgent care benefits, you're going to immediately get a referral and an authorization number to put on your claims. If the patient is not eligible for urgent care benefits, your registration team is going to need that information. So again, they can capture any other health insurance information or make sure to bill that patient directly. Emergent care notifications are the tough one, and I know there are a lot of questions around these notifications. We're all familiar with that strict 72-hour deadline that exists. These notifications can get tricky because they can be made by anyone associated with the visit. We make notifications on behalf of some of our clients. Many providers make them directly. The patient can also make a notification. There's a lot of information that's needed for these notifications because these notifications do not guarantee that an authorization is going to be created. The VA is opening a case to consider authorizing this care, depending on whether or not it is truly considered an emergency, and they utilize what they call the common layperson's definition of an emergency to determine what is and is not emergent care. They're also considering whether the service is the reason for the visit is service connected, excuse me. If the patient is being seen for something related to their military service, then the VA has an obligation to pay for it. They are also, again, considering the timeliness of the notification. A late notification is likely not going to result in an authorization. But it is important to make those notifications anyway, even if you have passed that 72-hour window, because there are 3 types of emergent care with the VA. They may decide to authorize that care, particularly if that notification was made timely and it appears to be a true emergency, even if it's not service connected. But if they determine they will not authorize this care, they do sort unauthorized emergency care into 2 different categories. They have the mill bill claims, where the VA is going to pay as the payer of last resort, but they may indicate that this care is service connected and that they should still be billed as primary. So the notification and any additional documentation they ask for, like medical records, is going to help them make those determinations. Joseph, do you want to talk a little bit more about billing and claims management?
Yes, thank you, Rebecca. So moving on to our third best practice, which is optimized billing and claims management. A few important topics here to discuss, but for authorized care, it's important to confirm which VA payer the authorization is assigned to. If the authorization is assigned to a VA-CCN payer, ensure that it's the correct VA-CCN payer for your region. This can always be located on an authorization letter that you've received from the VA. For your unauthorized care, it's important to confirm the category of care, as this will also determine your next billing steps. It's also important to identify the reason for not having a referral on file. For example, is it an issue with the patient's VA eligibility, or was this due to a late notification being made for their emergency treatment? The reason for an authorization not being provided by the VA will determine if you are legally obligated to bill the VA for a denial. Remember that it is always the provider's responsibility to ensure that an authorization is on file at the time of service, or that a timely notification of care is made to the VA. Therefore, if no authorization was obtained due to the lack of action by the provider can legally not bill the patient for that balance. And then also touching on the coordination of benefits for unauthorized ER care. The VA themselves will only be billed secondary in the case of unauthorized emergency care. In these cases, the VA is always going to be considered the payer of last resort and will be considered secondary to all commercial payers, Medicare, and liability coverages. The coordination of benefits between VA and state level payers is a little different, such as Medicaid, and it's a little bit more complex. For example, Aspirion's legal team has confirmed that Medicaid is primary in the state of Minnesota, but at this time, we have not been able to confirm the legal status for other states. Rebecca, would you like to cover the next couple of topics for us?
Absolutely. So like I mentioned earlier, timely filing is a big consideration. Knowing which payer you're dealing with does change your timely filing limits, as well as whether this care is authorized or not, as unauthorized care has much shorter limits. You do want to track these ever-evolving timely filing requirements on a payer-by-payer basis, as each of the 3 payers at one point in time has had completely separate requirements for timely filing. That's really going to play into working your claim rejections, as a rejected claim is not considered proof of timely by the VA. And this would be a front end 277 rejection that I'm talking to when I say rejections. The key to working rejections in our experience is really to dig into your basics. Most of the rejections we see are due to registration problems, like the patient's name spelling, that member ID format, and this does increase our need to contact patients if registration has dropped the ball on the front end. And always, always, always making sure that that authorization is on the claim and that it matches the referral paperwork exactly. You wouldn't think that transposing 2 digits in an authorization would make a big difference, but with the VA, it absolutely does. Even once you get past those rejections, denials with the VA are very complex, and there are a lot of different things that the VA will and does deny for. The other thing about these denials is they are not always what they appear to be at first glance. For instance, we have seen denials for invalid diagnosis code that actually referred to the diagnosis code not matching the authorization status, or denial for place of service code because the place of service code does not match the authorization on the claim either. So what appears to be a coding issue could be an authorization issue, or vice versa. These issues can be really complicated. This, again, can cause you to need to reach out to the patient well after initial billing, and that can cause delays. Making sure that you have all of the information needed to bill payers in the correct order is definitely going to be important. The VA only processes as a secondary payer, like we said, with those unauthorized emergency room claims. So that's where those denials for coordination of benefits come in, is that one instance. In every other instance, the emphasis really needs to be on verifying that the denial is not actually related to the authorization status. The VA generally processes based on Medicare guidelines, but they do have their own quirks as well, particularly when you consider that the CCN payers are commercial processors and not the VA themselves. And so information can be very, very payer dependent in terms of something as simple as how they would like the claim to be coded. Joseph, do you want to talk a little bit more about the tools we have available?
Yes, thank you, Rebecca. So it's really important to utilize all the VA tools that the VA makes available to us, so you can perform diligent follow-up work. Whether it's reaching out to the VA payer by phone or utilizing the portals they've made available to us. Both the VA and your third-party administrators, Optum and TriWest, have dedicated phone lines you can reach out to in regards to eligibility, authorizations, or any claim questions you may have. When it comes to the portals, the VA does have the CEP portal, otherwise known as the Customer Engagement Portal, and this is where you can check and obtain claim status for the claims that you've submitted directly to the VA. Optum, on the other hand, does have its own dedicated portal where you can access claims information, eligibility, and authorization information. When it comes to TriWest doesn't have its own dedicated portal. They utilize Availity through the Payer Spaces function, where you can also access authorization and claim information. For both of your TPAs, Optum and TriWest, they both actually do have a chat tool available as well, where you can speak to a lab representative. And the last thing is through Aspirion's investment and development, we've also found that RPA automation can be extremely successful obtaining claim status on our VA claims. And our fourth best practice is just to track your results. And it's really important to know why your claims aren't getting processed timely, and even more important to understand why they aren't getting paid. When it comes to reasons for the number of resubmissions you're having to file, are there workflow issues tied to registration that might need to be addressed internally to help prevent future resubmissions? Or are there common coding errors that are being made that may be causing unnecessary claim denials or rejections that need to be discussed internally? Next, what are the reason for the number of reconsiderations you're having to file? Are there actual processing errors on the payer side that need to be addressed specifically with the payer? Or are there more accurate coding practices that might be able to be put into place to prevent a number of those reconsiderations from having to be filed? Lastly, what are the reasons for your non-payments? Thank you. Lastly, what's the reasons for your non-payments? Is there no opportunity to collect on those charges at all? Or was the opportunity lost due to things such as untimely filing or a lack of obtaining an authorization before the services were provided? And now I'm going to pass things over to Rebecca, who's going to cover our fifth and last best practice for us.
Thanks, Joseph. Our last word of wisdom is just to stay up to date on policy changes. This is a really dynamic space working with these VA payers, and things are constantly changing, not only on a yearly basis, but sometimes on a quarterly basis. Very, very recently, we've had changes with CHAMP VA changing their timely filing requirements, as well as requiring EFT setup for any payers to be paid. They're no longer issuing any of their payments via check. We have that switch, as we mentioned, from the Social Security number to the MVI ICN, which was projected to happen, but actually has not been rolled into place yet. Who knows when it will happen in the future? We're still paying attention to the VA to find out. The VA does give you a lot of tools to stay on top of these continuous changes. You can see here information about that provider advisor setup, but just staying on top of good communication with those providers, we have found is the most effective way to stay on top of these policy changes. Lori, do you want to wrap us up?
Right. Well, thanks, Rebecca and Joseph. I know that concludes the materials that we prepared for you today. And just as a reminder, once we're finished, you will get that survey. So we really do appreciate your feedback. Now, we do have quite a few questions in the chat, so we're going to we do have a few minutes left. I know that was some of the feedback we got from earlier sessions, is that they wanted us to schedule the content so we actually had time to address the questions live. So we do have time for that. I do see that we have a couple of different questions around when should we be billing VA as secondary, specific to Medicare, Medicaid, other specific payers. And this is an issue that has gone back and forth. It's actually gone back and forth in the courts over the past several years. It's something that we monitor very closely. There's always another case that will pop up, and then depending on that ruling, it may change the rules. So you really, we've mentioned a lot of this evolves quite frequently. So I think maybe, Rebecca, can you just give us some information about when should you be billing VA as secondary and when is it not appropriate? Like in my understanding, and I could be wrong, it could have changed, anytime the VA authorizes the care, the VA should be the primary payer billed. And I don't know if there would be any secondary that would be paid at that time. So if you can just kind of walk us through some of those scenarios and try to clear up some of the confusion, that would be great.
Yes, you are absolutely correct. If there is a VA authorization on file for your episode of care, the VA should be billed as the primary and sole payer, which is where those rejections come in, with the VA payers rejecting claims where they are listed as the secondary payer because the care is authorized. Only in the case of unauthorized emergency care will the VA process as a secondary payer. In that instance, based on the laws and the ways that those laws are being interpreted in these ongoing court cases, the VA is considered the payer of last resort. That's the way it's worded. That is why there's some confusion about how that relates to Medicaid. Payer of last resort definitely makes them secondary to Medicare and liability in those cases, but the state level payers get complicated because of state by state laws and guidelines around where Medicaid falls as potential payer of last resort. So definitely I would consult with your legal team around those Medicaid guidelines if you're not certain with that unauthorized ER care if the VA should be billed as primary or secondary to Medicaid.
All right, thank you. Another question we have is, what advice do you have to do you give to keeping the payers straight and not mixing up the various payers within the VA system? Is that one, Joseph? Can you tackle that one?
Sure. So our best advice would be is always remember to think of the VA themselves as the entity that is coordinating that patient's care, whether it's sending them for a consultation, creating referral out to a community care provider. They are the ones who are controlling the coordination of that patient's care. By doing that, they create an authorization for specific services for the patient to be seen in the community, whether that's to follow up with a cardiologist in the community, a neurologist, orthopedic, whatever the case is. Then think of your third-party administrators, such as Optum or TriWest, as separate from the VA. But when the VA creates those authorizations based on the region that your facility resides in, all of that authorized care will need to be billed either to Optum or to TriWest as the third-party administrator that's going to process the claims for any authorized care.
All right, thanks, Joseph. All right, a couple more questions. One of them here, who has to ask for the authorization extension? The VA has always told us the patient has to request authorizations, and my auth team is not able to do so. Rebecca, do you have any experience with that particular issue?
Yes, again, this is going to depend on the actual care that's needed. So, for instance, an emergency care authorization can very easily be extended by a provider. They will likely ask for medical records in order to prove medical necessity of a lengthy stay following an emergency room admit. But if you do submit those medical records, the only reason the VA does not extend those emergency authorizations is if the patient was offered a transfer to the local VA hospital. Pre-scheduled care, that non-urgent, non-emergent care, is where things do become more complex, and you do need to coordinate very closely with your patients. Because these authorizations are being created by that local VA medical center directly, you may find it valuable to build contacts with that local VA medical center, as well as with your VA patients, in order to help handle obtaining those referrals and getting more insight into why, in some instances, submitting a request for services is sufficient, and in others, they are needing that patient to be involved.
Okay, thank you. So another question we have is, if a patient does not inform the provider of VA coverage until after the 180-day limit, can we bill the patient? Is the patient then responsible for payment of the service? I don't know which one of you wants to take that one.
Yeah, I can speak to that. That can sometimes be a tricky question for providers when they're looking at billing the patient, and it's something we deal with all the time. If the patient did not present their VA coverage at the time of service and they didn't notify you they had their VA coverage until after that timely filing was billed, it is our general understanding that's not at the provider's fault. And the patient can be billed in that situation. Rebecca, I'm not sure if you have any newer updates from the VA on that, or if you had anything additional you wanted to add.
It can definitely be complicated, especially sort of proving if the patient does push back that the delay was due to the patient not providing information. And you definitely want to make sure you had that clearly documented. I will say the VA in those instances is sometimes now accepting proof of you having billed other health insurance as proof of timely as well. So don't necessarily rule that out. If you did bill another health insurance, you may be able to submit that to the VA as proof of timely in order to prove that you did bill a insurance as quickly as possible, as well as making that argument that the delay was due to the patient not providing their VA information.
Okay, all right. Let me see what else we have time for. I know we're running close. I think this one, if the appointment is scheduled care, is it the responsibility of the patient to provide the auth at the time of the visit? I believe the answer to that is yes. Correct.
Yeah, ideally the patient would provide that authorization, but again, if you are a contracted community care network provider, if you do have those contracts with VA/CCN, that can get very complicated. The VA has given a lot of resources to providers to obtain those authorizations, all of those portals that we mentioned, as well as call centers, because for that non-emergent, non-urgent care, an authorization is required. Even if the patient is not providing one, I would definitely recommend doing an independent search to see if an authorization does or does not exist. And that is certainly something you would want to do before the patient was admitted for care.
Okay, thank you. So I see another question here. It says, may you please talk about mill bill? We have never overturned an unauthorized ED or hospital visit. Well, my understanding, the mill bill is the piece of the funding mechanism within the VA that provides the funds to cover non-service connected emergent care. And I think, as we mentioned, it is always going to be considered the payer of last resort. There are different eligibility requirements. where with some authorized care or other types of care, if the patient hasn't actually gone through an assessment, they can retro their eligibility within the VA. But for mill bill, not only do they already have to be registered as part of the VA, they also have to have been seen within 24 months. And then the reimbursement is only going to be 70% of Medicare, and there cannot be any other health insurance available to them or any other insurance. I don't know, Rebecca or Joseph, if you want to add anything. I know that this is where the Medicaid issue comes up on a state by state as to whether Medicaid is considered other insurance for VA purposes as a payer of last resort by the VA. So anything else that you guys want to add about mill bill claims that you've been seeing lately?
No, I think you covered it pretty well.
All right, and I think we covered if the patient has Medicare, should we be billing them primary and VA secondary even when an auth? The answer to that is no. If this authorized, the VA is the primary and exclusive payer. Now, you may have sometimes where the patient is coming in for authorized services and then there are other care that's being provided then the claim needs to be split. I don't know if that's something we want to, how often we're seeing that on our end. I know that's something that the VA does provide information out about that. But that's when you've got certain services that are authorized, and then there's other care that's being done that's not related. Anything that you guys want to add about that?
Yeah, I think split billing does get really complicated, and it is something that's sometimes necessary because of those authorization limitations. Not only will they potentially deny the entire claim if some of the services on the claim were not authorized, you also cannot have more than one authorization on a single claim. So if you have extended care and one authorization ends and the other picks up in the middle of that episode of care, you then have to split the claim on date lines in order to get the whole claim paid. So that can definitely be something complicated for both billing and potentially coding to step in and handle, but is sometimes necessary.
Well, I think we're at time. So great job, Rebecca and Joseph, for especially that last part where we put you on the spot, let you answer the questions live. You guys did a great job. If you guys notice on your screen, there's a QR code that takes you to our website, to our other educational offerings. There's a lot of recordings and webinars and content there. There's a lot more questions that you guys posted in the Q&A that we don't have time to answer live. But we will provide our answers to all of these, and we will get them back to those of you that are attending the webinar. So we'll provide those as follow-up. There may be a couple we may need to have some clarification from you, but we'll do the best we can with the way that you've posed your question in there. I think that's all we have today. And again, please take some time to give us some feedback on the survey, what you liked, what you didn't like, other topics you'd like to hear from. Our thought leadership team, wants to make sure we're providing really good, valuable content back in the form of these webinars. So, your input is greatly appreciated. So thank you all for your time today. And we look forward to hopefully hosting some of you on our next session. Thank you.